In case of papillary carcinoma of thyroid, which is limited to the gland, then only a total thyroidectomy is sufficient. If the nodule is less than 2 mm in size, you may or may not consider doing a hemithyroidectomy and following up the patient. So for that, the prerequisite should be that the patient is going to come for regular follow-up, and every 6 months you have to do an ultrasound test and serum thyroglobulin to see if it is raising in um, the every sequential visit. So after doing a total thyroidectomy, you have to give some adjuvant therapy in few cases. And ideally, for what I practice is I do a radioactive iodine minimum dose at least every patient post-operatively, because we never know when the patient has a metastatic disease. So if there is any residual thyroid tissue or any microscopic metastasis to the nodes or distant, the radioactive iodine can take care of them all. And the best part is, if you have done a complete radioactive ablation after doing a total thyroidectomy, your follow-up becomes very easy, because uh, you have something called biomarkers, right? So biochemically, you can look for thyroglobulin, which can elevate whenever there is thyroid tissue remaining. So once you are sure that you have removed all the thyroid tissue possible, then only your thyroglobulin will be at a minimum, because you're already going to suppress your thyroid by giving high dose of L-troxin or levothyroxine. And because of this, there won't be any uh, TSH will be minimal, and also your TG, that is thyroglobulin value, should be untraceable in your body. So main adjuvant therapy given in differentiated thyroid cancer is going to be radioactive iodine. Uh, Going into radioactive iodine in detail is for another time, and because it in itself is a very big thing. Some patients in which you are suspecting that they will not tolerate a long duration of hypothyroid state, which is required to give radioactive iodine, we can use something called a recombinant TSH, by which we can, giving 2 doses of recombinant TSH, we can reduce the hypothyroid time to less than 1 week. Then radiation therapy is usually given when there is a residual thyroid tissue, not microscopic, mind you, residual thyroid tissue that you have left in the neck, because whether it is adherent to the trachea, it is adherent to the nerve, or it was left inadvertently, or whether the disease is so bad involving the strap muscles or the esophagus or the trachea, where you have to shave off the disease from the trachea, then you can go for radiation therapy, external beam. Or in case of medullary carcinoma of thyroid, we use it as an adjuvant therapy in all cases. Chemotherapy role is not much as of now. So then how do you follow up the patient after you have completed the treatment is, once you do the iodine scan, you do a thyroid suppression by giving a high dose of levothyroxine. Usually the patients require only 1.6 times their body weight in case it's a benign disease. 1.6 times the body weight should be the number of milligrams of levothyroxine that you need to supplement. But if you want to suppress, you have to give double that. So generally, these patients are given a higher dose, are between 150 to 200 microgram of levothyroxine uh, on a daily basis. And after that, you have to follow up every 6 months. Since it's a very slow growing tumor and you're sure that you have a complete structural and biochemical response, you can ask the patient to come every 6 months with a serum TSH, serum thyroglobulin, which is a biomarker for any thyroid cells which are persistent in the body, and also antithyroid antibodies, which can tell you if there is any uh, structural change or functional change which is happening in the cellular level. And in every follow-up, ultrasound scan may or may not be done depending upon the stage of disease during the time of treatment. And if you find something suspicious, further investigations can always come. As you know, thyroid cancer has a very, very good prognosis once it is um, a differentiated thyroid cancer, that is either papillary or follicular variant. First and second stage, 100% cure. You cannot get that in any other disease. Okay, only thyroid cancer. In head and neck, you will get 100% cure rate in stage 1, stage 2, and even in higher stages, you have a very good overall survival rate. But as good as thyroid cancer is, anaplastic carcinoma is very bad, and that is why it is never staged as stage 1, stage 2, stage 3. It is always a stage 4 disease, and all the trials which are going on right now, none of which have been very successful as of yet, but they are all going on in anaplastic carcinoma because as of now we don't have a very significant cure. So, in differentiated carcinomas, we have seen that there is a bit of a dip when it comes to stage 3 and stage 4. But generally, which are the poor prognostic factors that you see is that when age is not very conducive, that is, in extremes of age, children, when they have thyroid cancer, they have very bad presentation. They have extensive nodes. They will have big enlargement of thyroid stuck to the nerves and everything. And also, when it comes in elderly, it is more likely to be de-differentiated and cause more high risk uh, thyroid cancer. Males, as I said earlier, they have a very bad prognosis in case of thyroid cancer, and familial thyroid cancers also generally tend to be bad, especially the medullary carcinomas. Then um, other variables which you can see is extrathyroidal extension, extensive vascular invasion, mediastinal nodes, cervical lymph nodes which are hard during palpation or during surgery, extracapsular extension of the nodes, and then certain subtypes of the tumor, which are like Hurthle cell, tall cell, columnar, and diffuse sclerosing variant and insular variants. These are quite poor in their prognosis, and also when the patient is presenting with distant metastasis, you expect that it is going to be a poor prognosis.